let's begin our session this morning with Umar Kitab Al-Fatihah. Okay. Is it, can you hear me clearly?
Yes, Doctor.
Dengar clear? Let me set this. All right. Okay, what's the topic this morning?
Kejap Doktor, ada 10 partisipan je sekarang. Saya tak sure kenapa diorang left.
10 je ada.
Wi-Fi Doktor, Wi-Fi.
Wi-Fi mahalah program Doktor.
Wi-Fi kita tak bagus kan?
Dia on off macam tu.
Ya. Yeah.
So better guna data lah kalau kelas.
Data guna data kalau kelas. This is not good. Okay. I'll feed that information to our profs lah, to our bosses. This is not right. Might as well do lecture dekat lecture hall ke mana. We can still do social distancing. This is not right. Okay. Should we wait a bit more or how? Okay. All right. Okay. This morning we're going to talk briefly about newborn examination. So after this, I think we will have 6 groups to actually do proper newborn examination. What's the difference between examining a newborn, between doing a newborn examination and doing examination in other patients, in other children, or even in a newborn with problems? What's the difference between this newborn examination and an examination of a newborn with a specific problem, or any other children or any other adults with a specific problem? What's the difference? Is there any difference?
Yes, for the newborn we need to examine thoroughly for all the systems.
So the idea is, when you have a problem, when you have a specific problem, you know what's your focus, what's your target. Yes, you need to do generalized examination, but there's a target. There's a diagnosis that you're thinking of. When you do examination, you've got some information. So the examination will be a targeted examination of sort. You will have a provisional diagnosis in your mind. You'll have some differential diagnosis that you have in your mind that you need to rule out as well. And you have the complications that you need to look for, complications of the disease and complications of the treatment that you need to look for. That covers the 5 objectives of any presentation that I always mention, isn't it? Okay, so, but in the basic newborn examination, you don't actually have any problem. So they should be, so most of newborns are actually normal newborns, normal human. So, and what we are doing is actually we are assessing the baby. We are assessing whether the baby is normal. Just to make sure that you're able to identify normal findings, and then basically to rule out other abnormalities. So that is the first understanding that you need to understand. Okay, let me share my slide. All right. Hi, can you see my slide? Is it clear?
Yes, Doctor.
Okay, so again, this is another slide by Dr. Syed. When you do a newborn examination, it is the most thorough perinatal exam. It must be done by the undergraduate, or so it must be a very thorough examination. So sometimes we do in several phases. We do at the first hour of life just to assess there's so many things that you need to assess at the first hour of life. The ABGA score, the condition of the baby. So there's so many assessment that you do in the first hour of life. And then another phase around 2 to 3 hours of life. So there are basically different finding, and then phase 3 to 12 hours, and sometimes you will do examination at first 24 hours, that and sometimes before on discharge, and you also assess the baby again at around 6 weeks or 8 weeks upon discharge. Okay, all right. So in the delivery room and the first hour of life, so basically important things is you need to look for the adaptation of extrauterine life. So how the baby adapts from in utero to extrauterine life. So these are the things that you need to look for. You assess for Apgar score. You look for any dysmorphism. But a newborn child at the first hour of life, the first day of life actually, dysmorphism is not that easy to appreciate. Because why? Because after birth, so in utero kan, baby is well fed, well nourished from mother, and then usually the first 24 hours of life they are a bit edematous, their skin is a bit friable, they are edematous. The whole body is edematous. So when they're edematous, sometimes it may obscure things. And also sometimes kan, especially kalau babies yang breech babies kan, because of the upper pole of the uterus, you can see the head shape is a bit different. So sometimes we don't, adik ni, baby ni is dysmorphic apa, but actually it's just because the baby is breech. So sometimes because they are breech, the shape of the head will be a bit different. The shape of the lower limb as well, sometimes dia nampak a bit different, but then that will change. If it's not a structural problem, sometimes it may normalize within the next 24 hours or so. You look for major congenital anomalies. You look for any signs of birth injury, especially if you think that they are at risk. Which sort of babies are at risk for birth injuries? So babies who are born with instrumental deliveries, and babies who are born with instrumental deliveries, they are more at risk for birth injury. Babies who are large for gestational age, babies who are infants of diabetic mother, babies whose mother has CPD, cephalopelvic disproportion. So this sort of babies, they are at risk for birth injury. What sort of birth injury? What sort of birth injury? Shoulder dystocia and all those complications. Okay, and then you assess for gestational age as well. Does the baby, yesterday we did NRP kan? So does the baby look term, or the baby looks premature? Because sometimes dating by the menstrual period, sometimes it may not be accurate, and sometimes dating scan also is not done early. Right? So those are the things. So you assess for gestational age, and then you assess for cardiovascular and support. So you need to do, what do you support? You support thermoregulation. You need to make sure that the baby is well controlled, well stabilized in terms of thermoregulation. I've told you before, newborn babies, they cannot control their own body temperature. So if you wrap the baby a bit more, baby will become feverish, will have hyperthermia. If you don't wrap the baby enough, and the baby will go into hypothermia. And then you assess the other effects, and then you need to make sure that the baby passes urine within the first 24 hours and passes meconium within the first 24 hours as well. Right? Why I cannot do this? Okay, all right. So Apgar score, you assess at 1 minute, 5 minutes, and then 10 minutes, and so on and so forth. So basically, it is meant to identify the need for neonatal resuscitation and diagnosis of perinatal asphyxia. But the main purpose of Apgar score is actually prognostication. So if the Apgar score is low, the main benefit is actually for prognostication. And you look at the parameters in score. Why? Right, so these are the Apgar score. So you rate to 0, 1, and 2. You look at the color, you look at the heart rate, reflexes, or grimace. and then muscle tone and activity of the child, and also respiration. So and then you score 0 to 2. So the maximum is 10 lah. Sometimes it's difficult to change the slide. Okay. Fine. Okay. So you look for signs of respiratory distress. So what are the signs of respiratory distress? The child may be persistent cyanosis, and you look for grunting. What is grunting? Because we are not English speaker, our native language is not English. So sometimes even grunting may confuse us. But for English speaking person, grunting is nothing. Grunting means grunting, like they understand clearly. What is grunting? How is this grunting sound?
Sound made to open up the airway because forces up against the closed airway. So like mendengus.
Mendengus.
Like
My Malay is not that good to understand mendengus, but I assume betul lah, good. So basically what happens is the child closes the upper airway, they close the vocal cord dia, and they increase the intrathoracic pressure, kan? So they close dia punya vocal cord, and then they increase the intrathoracic pressure, kan? So what happens is with the increment of thoracic pressure, you close the vocal cord. What's going to happen is the airway is going to open up. So dia punya so they close dia punya vocal cord, and then they increase the thoracic pressure. So it's going to try and open up the airway and things. So you can see this in TTN, you can see this in congenital pneumonias, you can see this in so many other problems as well in newborn especially. So grunting respiration. So and then nasopharynx, you can see chest retraction, subcostal recessions, all those recessions lah, subcostal, intercostal, suprasternal, and things. And then you look at respiratory rate as well. You need to remember that in newborns, the respiratory rate is more than the normal respiratory rate is maybe up to 60. So if there's tachypnea, the respiratory rate may be more than 60, and then tachycardia as well, or bradycardia as well. So among the commonest cause for respiratory distress is actually transient tachypnea of newborn. It's very common, and you need to remember that TTN usually they are not persistent more than 4 hours usually. And then RDS, there's so many situations can cause RDS, not just prematurity. Sometimes we may assume premature baby saja yang boleh go into RDS, but you need to remember other type of problems as well can develop into RDS. For example, apa cases yang boleh cause RDS?
Meconium aspiration syndrome.
So meconium aspiration pun boleh cause RDS. Macam mana dia cause RDS? How meconium causes RDS?
Meconium aspiration dia denature the surfactant.
Yeah, they denature the surfactant. It inactivates the surfactant. So the RDS is basically surfactant punya problem. The surfactant inactivation. It may be surfactant deficiency. Basically, it's sort of like a hyaline membrane disease kan. Also, what else? Satu meconium. Like apa lagi yang boleh cause RDS? Infant of diabetic mothers, infant of diabetic mothers are at risk for RDS as well, among others. Okay, all right. And then it can also be because of non-respiratory. A tachypnic child, probably not just respiratory. It can be other causes. It can be cardiovascular causes. It may be the first sign of cardiac failure. It may be the first signs of cardiac failure. It can be, is it because of metabolic problem? Is it because of the child is hypoglycemic, for example, hyperuremic, for example, hyperammonemic, for example. So it may be features of that, or the child may be septic, or the child may even have just a problem with temperature, thermoregulatory problem. So thermoregulatory problem can also cause the child to be tachypnic. So usually is hyperthermia lah, temperature, high temperature. The child usually can be tachypneic. If the hypothermia, usually it is more of low respiratory rate. So as mentioned before, how baby loses heat. So it can be because of evaporation, like we discussed yesterday. So when water changes into evaporation, it can be because of convection, it can be because of radiation, it can be because of conduction. So conduction ni contohnya macam kita letak thermal mattress lah. Kita letak thermal mattress because of conduction. So and then how to prevent heat loss by radiation? Itu yang kita letak dalam plastic bag, kita letak baby dalam incubator. All these are mechanism to reduce heat loss lah. And then normal vital sign as here is 36.5 to 37.5 lah usually. And then heart rate is 110 to 160. Respiratory rate usually it shouldn't go below 30 and it shouldn't go above 60 as usual. And then blood pressure usually we look at the gestational age. Maknanya kalau term baby dia punya mean blood pressure is usually around 40. Kalau premature baby, kalau dia premature 30 weeks, so dia punya mean arterial blood pressure akan jadi 30 lah. So 30. So mean arterial blood pressure usually is around the gestational age of the baby. And good oxygen saturation as well. So we need to document the baby voids. So passes urine should have both passes urine and also opening bowel in the first 24 hours of life. So bila kita nak worry, biasanya kita worry especially kalau abdomen start to become distended. Okay, and then gestational age. How do we assess gestational age? There are several methods. But the commonest is actually you use ballot scoring. So ballot scoring ni is a very quick assessment, tapi you just nak kena remember lah. And then you can assess what's the gestational age of the baby. So this is example of a ballot scoring. So we assess the posture, the square window of the wrist. You look at the square window of the wrist. So kalau macam dia very premature, dia tak boleh, dia macam tu je. Kalau more term baby, you boleh flex lagi. Okay. Then you look at the arm recoil. Arm recoil ni, dia punya arm dia. Kalau you straightkan tangan dia, kan? Lepas tu dia recoil balik tak? So in the term baby, bila dia straightkan, dia akan recoil balik. So but in a very premature baby, if you straightkan, dia tak recoil balik. You look at the popliteal angle, angle kat dia punya knee tu, berapa dia punya angle dia, you do scuff sign ni, you straight macam tu. Kan? Berapa banyak? Kalau more premature baby, obviously you can cross jauh lah. So and all these things, you look at the skin, you look at the breast, you look at the eye, ears, genital, and so on and so forth. So this is a very good and very useful assessment tool, ballot scoring. So and then so basically another quick assessment for gestational age, you look at skin, you look at the vernix. So usually more term baby yang ada banyak vernix, and then the hair and everything. Okay, correction usually it's more in the term baby lah. Lanugo. So if a bundle lanugo, banyak lanugo ni back hair rambut kat belakang ni hair kat belakang ni. So this is more bundle lanugo ni is more premature the baby lah usually. Kan preterm baby ni ear dia lembik je. Kan you lipat ni dia tak timbul balik, tak back to normal. So this is ear of a preterm baby. And then areola as well. So areola dia punya breast dia. Kan? So sometimes kalau very premature baby dia flat, tak ada butt pun tak ada. So dia ada assessment and you can look at the ballot scoring. Sole creases, kalau tak ada sole, tak ada crease langsung, flat saja. Sometimes it shows that it is more premature baby. Sometimes dia ada upper 1/3 saja dan sebagainya. So you look at the sole creases. These are very useful assessment tool. And then a very preterm baby, can you see the labia is a bit different kan? Dia punya minora dia nampak more prominent, majora dia nampak small saja. So these are signs of very premature baby. So preterm and term. Which one is preterm? Which one is term? So the one on the left is premature kan? Ini term baby. So term genitalia dia punya majora dia lebih prominent lah. So male genitalia pun sama, you akan tengok kalau ni term lah kan, dia banyak dia punya crease dia. Tapi kalau premature baby sometimes tak ada crease, sometimes dia almost flat pun ada. So resting posture, tengok. So ni yang involve things macam arm recoil apa semua. So kalau term baby on the far right here, term baby kan tangan dia pun macam tu. So muscle tone dia dah strong, dia dah macam tu. Tapi kalau premature baby dia more extended macam tu. So this is the resting posture of the baby. Kan? So because they are more scrawny, they are more small, the muscle tone is not that strong, so they tend to assume this posture on the left here. Okay, so when you look at neurological assessment, you look at reflexes. So sometimes more premature the baby, there'll be more head lag. Then you look for the primitive reflexes. Contohnya Moro reflex. What is Moro's reflex? Moro's reflex ni apa? Moro's reflex. Moro ni nama orang lah, kan? So basically, it's when you drop a bit the head of the baby, dia akan stretch and then dia recoil. So this is Moro's reflex. So Moro's reflex should be symmetrical. It should be present and it should be symmetrical. Bila Moro's reflex ni kalau ada, dia banyak abnormal. When a baby still have Moro's reflex, it is considered as abnormal. Moro's reflex ni dia patutnya hilang bila? Anyone has any idea? Zafira? Nur Zafira? Any idea when Moro's presence of Moro's reflex is abnormal?
Okay, 6 months.
6 to 8 months lah. So kalau dia still persist after 8 months, it is considered as abnormal. Kenapa dia abnormal? Because Moro's reflex, bila you drop macam tu, dia akan stretch and then dia recoil. So what reflexes appear at around 8 months? Parachute reflex. What is parachute reflex? Parachute, dia ada forward parachute, dia ada backward parachute, dia ada lateral parachute. Parachute ni apa? Parachute ni bila you tolak baby ke depan, dia akan outstretch dia punya tangan. Itu that is forward parachute. Bila you stretch baby ke belakang, dia akan stretch tangan ke belakang. Bila you sengitkan baby ke kanan, dia akan outstretch ke situ. Bila you stretch dia akan stretch situ. So this is protective reflex. This parachute reflex is the reflex that help you stabilize your body. Faham? Without parachute reflex, you cannot sit. You tak boleh nak berdiri. So, parachute reflex ni yang control the stability of your body. Kalau by 8 months, bila you dah ada parachute reflex, you still have Moro's reflex. Satu, with Moro's reflex, you takkan develop parachute reflex. Yang kedua, kalau ada Moro's reflex, you cannot sit, you cannot stand, you cannot everything because gerak sikit macam tu, gerak sikit macam tu. So you cannot, it's difficult. So that is why usually Moro's reflex, if there is still Moro's reflex by around 8 months, this is abnormal. Rooting reflex, what is rooting reflex? Bila you letak benda dekat area pipi dia akan root dia akan cari. So this is rooting reflex. Sucking reflex, so sucking reflex is another primitive reflex as well. You put anything in the baby's mouth, the baby will suck. So this is sucking reflex. Dia ada tonic neck, asymmetrical tonic neck reflex. So asymmetrical tonic neck reflex ni fencing position. Bila you pusingkan kepala dia macam ni, dia akan assume fencing position. Pusing ni dia akan assume fencing. Tangan dan kaki semua macam tu. That is asymmetrical tonic neck reflex. Stepping reflex. What is stepping reflex? Stepping reflex ni, contoh ni Can you see me? You nampak tak? So contoh ni kaki baby kan. Kalau you letak below the surface, you letak macam ni, dia akan step. You letak kaki dia kan, ni kaki dia, you letak bawah ni, dia akan step atas. So that is stepping reflex. And then ada walking reflex. You pernah tengok tak video viral dekat YouTube? Kata oh bijak ni baby ni boleh baru lahir dia pandai jalan kan. Actually semua baby macam tu. You all semua sama macam tu kan. So you letak ini baby, you letak dia punya, you pegang dia, you letak kaki dia dekat atas satu flat surface, dia memang akan jalan. That is a primitive reflex. So it is not something, itu bukan something yang miracle. Maksudnya semua baby boleh buat lah basically. So walking reflex, magnet reflex I'm not quite familiar. And then grasp. If you put anything on the hand, baby akan grasp. You letak anything on the foot pun dia punya kaki dia, jari dia akan grasp. Okay, alright. Let's go to the next. So head leg. So you assess the head leg. You check for Morose reflex. Tonic neck reflex, as I said, you turn the head sebelah, dia akan assume fencing position kan, macam ni kan. So yang belah yang kepala dia pusing tu, dia akan extend a bit, and dia opposite side ni dia akan flex. Dancing sama dengan walking reflex lah sebenarnya. And then sucking reflex and rotating as well. Hand grasp, you letak anything dekat tangan dia akan grasp. Foot, palma, plantar grasp pun sama kan. So the palmar grasp and also plantar grasp. Okay, alright. So and then you do basically head to toe examination. You look at the head circumference, look at molding or any abnormality in the scalp. So you can have kaput, especially baby yang lama sikit, dia punya second stage for example. You can see kaput succedaneum, you can see cephal hematoma, you can see subaponeurotic hemorrhage. So what's the difference between SAH? SAH ni is subaponeurotic hemorrhage kan? Subaponeurotic hemorrhage ataupun subgaleal hemorrhage kan? So apa beza? How do we differentiate between SAH, subaponeurotic hemorrhage and also cephalohematoma?
Sama ada dia extend beyond the fissure ke tak.
Okay, kenapa which one yang extend beyond the fissure?
Kalau subaponeurotic hemorrhage dia akan extend beyond the fissure.
Kenapa cephalohematoma tak extend beyond the fissure?
Sebab based on the layers of the hemorrhage located. Kalau untuk cephalohematoma dia between the skull and also the periosteum.
Okay, so the bleeding is below the periosteum. So the periosteum, it binds it circles the skull bone lah, kan? So it won't extend beyond it. Sebab itu cephalohematoma ni walaupun it's painful upon its nail, tapi the blood loss is not that much because it's bounded by the periosteum, bounded by the bone. Tapi in subaponeurotic hemorrhage, it is actually continuous the whole body. You can bleed up to the toe. From the head, it can bleed up to the toe. You can bleed into the anterior abdomen and so on and so forth. So it's a huge potential space at the subaponeurotic area. And it is a venous bleeding. Subaponeurotic hemorrhage is a venous bleeding. You know, if it's a venous bleeding, vein have the smooth muscle in the vein is actually not as strong as the artery. So bila the vasoconstriction, it doesn't close that well. So venous bleeding usually lambat sikit stop as compared to arterial bleeding. Arterial spurt, dia cepat keluar banyak tapi dia senang nak stop. Tapi kalau venous bleeding, sometimes it's a bit slow to actually stop. So that's the problem with subaponeurotic hemorrhage. You look at fontanelles, anterior fontanelle ni close bila, posterior usually closes much earlier lah, around second month tu dia dah start tutup. The problem you need to look at is actually if the early closure of the fontanelle. So it is abnormal as well. So molding is basically because of how the baby's head is positioned in mom's pelvis. So kalau dia compress tu dia bukan abnormal lah. The head is not abnormal. It's just because of molding of the head inside mother punya pelvis. So usually this will normalize after not so long. So cephal hematoma, that's one side. And then difference between caput succedaneum and cephal hematoma. And then you look at the eyes, you look at the placement of the eye, is there slanting of the eyes, whether the right reflex are present. Kalau absent right reflex, what does it mean? What does it
Di
mean?
Glaucoma.
retinoblastoma.
So it means there is leukocoria,
Cataract.
for example. So there's leukocoria, cataract. So then you need to look for what are the causes for leukocoria or cataract in children lah. Kan, retinoblastoma, congenital infection. Apa congenital infection yang can cause cataract?
CRS.
Huh?
Congenital rubella syndrome.
Yes, congenital rubella, congenital rubella. We still see congenital rubella even now. Look at the epicanthal folds. You look at the child should be able to blink. Bila stroke ni dia patut blink dan sebagainya. If there any discharges, pupillary reaction, the baby should follow to midline. Okay, alright. And then hearing as well. The baby should respond to sound, walaupun dia tak dengar betul, tapi dia should overall the baby should respond to sound. You look at the placement of the ears, whether there's any low set ear. Dia ada external auditory meatus, dia ada tak? Sometimes dia nampak earlobe tu ada tapi tak ada lubang. For example, I've seen dia earlobe nampak normal tapi tak ada lubang. Kan? Dia ada sinuses tak? So sometimes some sinuses are dia ada ear tag tak? So right ear skin tag sometimes, for example, associated with kidney abnormalities. So look for all those things. And then so basically it's a head to toe examination. You can start from head and then you go down. So head tu you tengok dari semua dysmorphism semua, and then after you settle, you go to respiratory and cardiovascular. So you assess again. Some murmur like VSD, it may appear late. Kenapa dia appear late? Kenapa dia appear lambat? Why usually VSD murmur? You usually hear VSD murmur, for example, only after day 5 of life. Kenapa? Any reason why? Something I've mentioned.
When the pulmonary artery pressure has reduced.
Yes, because of pulmonary pressure. Kan? Pulmonary pressure. So again, what causes murmur? What causes sound? Because of turbulence. What causes the turbulence? Turbulence flow is caused by the shunting of blood, shunting of the fluid, movement of fluid through a restricted area. So that restriction of movement, that small restriction, small obstruction, causes the turbulence flow. Kan? For that shunting to happen, dia mesti ada pressure gradient from left side. Kan? Usually left side is higher than the right side. Kan? If you look at VSD, if you look at the ventricles at diastolic, dia punya blood pressure, dia punya pressure in the left ventricle and right ventricle at diastolic usually is around the same, not that much different. Sebab itu VSD masa diastolic tak ada murmur sebab blood pressure dia between left ventricle and right ventricle dia is around the same. But the moment systolic occurs, the ventricle starts to contract. What happens? The left ventricle is stronger, it has more volume, so it contracts harder. And then dia nak kena pump to whole body. Right side, right ventricle is smaller in terms of the muscle size. Kan? Dia punya structure is less as if you compare with left ventricle. And dia pump dekat je, pump to the lung sahaja. So dia tak boleh pump kuat-kuat sangat, dia pump kokoh je. Kan? So the moment this happens, so the systolic, the pressure generated is higher in the left ventricle as compared to the right ventricle. So because of this pressure gradient, if there is a hole in between the septum, there will be shunting left to right. So the smaller the lumen, the more turbulence flow created because there's two chambers. There's a small lumen, macam kita tekan pipe yang ketah pipe, kita tekan kat depan tu. The smaller the lumen, the more turbulence flow created. Kan? Lumen besar, volume yang keluar tu sama. You buka pipe, ada getah dia kan. Dia punya volume yang keluar tu sama. Tapi you constrict the you letak valve kat depan tu dengan jari ke apa, dia akan turbulence flow. Tapi kalau you buka besar, dia akan flow dia laminar flow, kan? Tapi volume yang keluar sama. Sama macam VSD, kan? Kalau you constrict, dia punya small, lumen dia small, turbulence flow banyak turbulence flow, sound dia akan lagi kuat. Tapi kalau lubang dia besar, sound dia tak kuat sebab less turbulence flow created. Tapi another factor is the right ventricular pressure, the right side pressure, pulmonary pressure. So kalau high pulmonary pressure, shunting dia tak banyak lah, kan? Sebab masa systolic pressure gradient dia tak banyak sangat. So sometimes in the first 5 days usually right-sided pressure is still high. So you cannot appreciate that much dia punya VSD murmur dia. So sometimes some murmur are not very apparent the first 5 days of life. And sometimes there are murmur yang ada masa first week of life je. For example, PDA. Sometimes PDA, you can hear PDA, but PDA sometimes we've discussed before, kan? So PDA, macam ni PDA close? By the action of your oxygen, kan? Increase in PaO2, increase in arterial oxygen concentration, kan? Effect of the basically prostaglandin. So all this causes PDA to close. Sometimes it takes time, sometimes 5 days baru PDA to close. Sebab itu contohnya problem macam tetralogy of Fallot, for example, or certain ductal dependent lesion, kan? Certain ductal dependent lesion, masa first 5 days tu, okay, the moment duct dia close, baru problem may happen. So sometimes PDA, what I'm trying to say is PDA sometimes, kan? Sometimes you can hear PDA, but after 5-7 days dia hilang. And then obviously you know that heart sound dia akan differ with patient punya condition. Patient tu fluid overloaded, ada murmur. Patient tu temperature tinggi, you dengar murmur yang lain. Patient tu heart rate newborn ni dah lah normal up to 160. Is it easy to appreciate murmur when your heart rate is 160? Sometimes dia naik sampai 190, kan? Is it easy to appreciate murmur at heart rate of 190? It's not easy lah, kan? Bila dia tachycardic, sometimes you can hear gallop rhythm. But gallop rhythm at 190 heart rate, it's not easy. It's not easy to appreciate lah, kan? So that's the problem. So you look at femoral pulses kena check. Kenapa kita kena check femoral pulse especially? Apa disease yang boleh problem dia dengan femoral pulse?
Coarctation of aorta.
Coarctation of aorta. So you can sometimes you won't feel femoral pulse, or it will be less as compared to brachial pulses. Okay, again, assessment of respiratory status. You look at the chest. You look at the chest, chest size and things. So brachial pulses, femoral pulses, you need to compare. Musculoskeletal, again, you look at symmetry. The baby they should move bukan serentak sama lah. Maksudnya it should move all 4 limbs in a symmetrical manner. Sorry, let me see. Call. Alright. So you assess, there should be complete 5 toes and 5 fingers, sebab sometimes people miss polydactyly. Do understand why? And now we can do so many things, kan? Ada satu very glamour punya actor ada polydactyly. Seorang pelakon very glamour, very popular actor ada polydactyly. Rintik Roshan ada polydactyly, kan? Sebab tu tangan dia salam aku macam tu, kan? Apa Rintik Roshan ni? Okay, you look at the clavicle, especially babies with shoulder dystocia, sometimes they have clavicular fracture and things. Not just that, clavicle, I've seen humeral fracture. I've even seen femoral fracture. And I look for the clubfoot, any curvature, any abnormalities of the sacral, sacral agenesis, apa semua, sacral dimple. Sometimes sacral dimple can be a sign of spina bifida, and then you do Otolani and Balu test to look for clicky hips to look for displaced displaced hip joint. So you do otolani and balu test. Otolani and balu test. So otolani is where you move the hip, ni keluar. So you keluarkan, you dislocate the hip joint, and balu ni basically you masuk balik lah. Dia akan ada click dia. So make sure nanti bila you go by the bedside, kita try and practice and then look for skin folds, look for everything, and then genitals. Okay, genital you need to remember okay, things macam sometimes if you see some bit of blood, so it can be normal pseudo menstruation, and then assess the placement of the testis. Male baby, you should always assess where is the testis. So sometimes if the testis is intra-abdominal, sometimes you need to assess because there's a risk for a malignant change. So you need to assess where. Kalau you tak rasa dia punya testis dekat dalam dia punya scrotum, you need to look for it. Where is it? Kalau you tak jumpa, you need to ask for ultrasound lah, because you need to locate where is the testis. So passage of meconium, always check patency of the anus. Macam mana nak check patency of the anus? How do you check?
Use rice tube.
Rice tube. Okay, zaman-zaman dulu kita guna thermometer kan, dia ada rectal thermometer. But the problem is there's risk you guna rectal thermometer, dia boleh break dan sebagainya. Don't use your finger kan. Kalau jari besar macam jari aklan tu jangan buat. So don't use your thumb. That's definitely kan. So you can use rice tube lah, you can use rice tube. You can actually look at, tengok buka, nampak. I still see people missing imperforated anus. I still see after the few days baru diagnose imperforated anus. So this is a problem lah. This is why among the reason dekat UIA sekarang, our Sultan Ahmad Shah Medical Center, now all newborn assessment will be done by by pediatric staff. Our pediatric MO yang akan buat. Sebab kita nak kurangkan risk of missing all these things. The abdomen should be soft and non-tender. Kalau abdomen di scaphoid, lepas tu tachypneic. So you need to think of CDH lah, for example. And then bowel sounds are present. Umbilical cord, you need to look ada berapa artery, ada berapa vein. Ada berapa artery, ada berapa vein.
One vein, two arteries.
So one vein, two artery, two artery, one vein. And then look at the skin, spot one stain, milias, apa semua benda. And then jaundice. So jaundice within the first 24 hours is always pathological. Within the first 24 hours, kalau baby ke jaundice, it should always be pathological. Okay, phototherapy. So what does phototherapy do? Kita buat phototherapy ni apa? Apa effect of phototherapy? Kenapa kita bagi phototherapy in babies who have jaundice?
It convert the unconjugated bilirubin to the conjugated.
No.
Atau isomerize.
So basically you remember, kalau dalam neonatal jaundice ni, dia conjugated ke unconjugated bilirubin?
Unconjugated.
Unconjugated. So unconjugated. So unconjugated bilirubin kan, nanti dia akan bind after dia unconjugated bilirubin, lepas tu dia akan bind to albumin, akan bawa kepada liver and then be conjugated. So unconjugated bilirubin is lipophilic and hydrophobic. So unconjugated bilirubin is lipophilic and hydrophobic. That's the nature. Being hydrophobic, they are not excreted by your GI and GU. They are not excreted by your gastro-urinary tract. They are not excreted by your genito-urinary tract. It is not excreted by your kidney because they are hydrophobic. And being lipophilic, they can cross your blood-brain barrier. So the moment, that's the problem, bila dia cross blood-brain barrier, dia boleh deposit dekat your brain and causing all the bilirubin encephalopathy lah, bind bilirubin induced neurological disorder, kan? So they can cause all the problems. Sebab itu kalau jaundice more than 14 days in term, more than 21 days in preterm, kita tak peduli sangat dengan fisioterapi, dengan fototerapi ke apa. Sebab we assume after 14 days, dia punya blood-brain barrier is more mature. So bilirubin tak cross that much into the brain. Kita tak worry sangat. Okay. So what happens dengan fototerapi ni? What happens is photoisomerization. Photoisomerization. So it changes the molecule. It doesn't conjugate the bilirubin because conjugation happens in the liver. Kan? So what phototherapy does, they expose the blue, dia bukan blue light. The frequency of the light is what that causes all these changes. So it may be whatever color yang you nak letak. So the color is not important, but the color determines the frequency. Kan? Blue color has different frequency, red color has different frequency. This frequency is the one that causes the photoisomerization. So studies now kata blue light ni is the best frequency yang boleh cause these changes. So dia photoisomerize daripada lipophilic hydrophobic, it changes into more hydrophilic punya nature. It just changes the velocity of the unconjugated bilirubin. So bila dia more hydrophilic, what's going to happen? Dia boleh be excreted by your genitourinary tract and also by your GI as well. Tapi provided baby kena pass urine lah. Kalau baby tu dry, dia tak pass urine, macam mana you nak hilang dia punya, kalau baby tak open bowel, macam mana nak hilang dia punya jaundice? Kan? So this is what happens when you give phototherapy. So photoisomerization. If you look sekarang study banyak dia going back to white light. They're going back to white light. Sebab itu light source ni pun important. You need to remember several things. Contohnya kalau lampu tu jauh, kan? It doesn't have that much effect. Sebab frequency, you remember frequency, distance is important. Kalau frekuensi dia tinggi, bila dia jauh, kan, dia akan lose dia punya frekuensi dia. Kan, frekuensi tinggi, bila jauh dia akan lose dia punya frekuensi. Higher frekuensi dia tak pergi jauh. Lower frekuensi dia pergi jauh. Faham? So distance between the source of the light dengan baby itu is important. Sama juga dengan frekuensi. Blue light ni dia ada banyak range. So what is the range of the frequency is important. Lepas tu you need to remember satu lagi, thermoregulation. Kan? Sebab bila you nak expose baby, you kena bonggir dengan baby tu kan, tutup mata. Kan? So zaman dulu-dulu, I remember I have D6PD deficient. I have severe jaundice as well. Masa kecil dulu, I'm born premature, IUGR, ada GCPD deficient, ada severe jaundice dulu. So I tengok gambar-gambar dulu, ada banyak gambar mak jemur kat tengah panas kan, dekat matahari, tutup mata, jemur kat matahari. Sebab dulu orang believe if you light matahari ada blue light kan, so you boleh reduce jaundice. Now don't do this anymore. Dulu orang buat, I think 1985 orang dah stop doing stuff kan. So bila kita expose budak tu, obviously the baby may be prone to have problem with thermoregulation lah kan. Kalau dulu-dulu banyak orang pakai dekat HTA pun still ada, dia pakai fluorescent lamp. What's the problem with this fluorescent lamp? Fluorescent lamp produces heat. Dia panas. Dia produces heat. Bila dia produce heat, baby boleh dry, baby boleh dehydrated, baby boleh hyperthermia. Kan? So that's the problem with fluorescent light. So you nak kena make sure baby is well hydrated dan sebagainya. Tapi sekarang ni, lampu kita guna dekat UIA, kita guna lampu macam mana? Kita guna LED punya light. LED. So LED punya light doesn't produce heat. So kalau you letak baby dekat open dalam kita punya NICU yang sejuk dengan aircon, you letak LED, baby can become hypothermic. Dia akan jadi sejuk sebab LED light doesn't produce heat. Kan? So you need to think macam mana nak buat. So you kena control you punya thermoregulation. Sometimes you ada yang macam Billy blanket. Billy blanket ni dia pakai fiber optic. Fiber optic also doesn't produce heat. Kan? Doesn't produce heat. So kita kena maintain dia punya thermoregulation. Extend transfusion, and then sometimes you can see this conjunctival hemorrhage. Conjunctival hemorrhage ni sometimes after after cesarean section, after instrumental delivery. And then breast ni biasalah, is common. You can see natal tooth. Okay, one stain, skin. So okay, that's it. So basically, newborn examination is an assessment mainly of a normal baby. So you are looking for any abnormality that's present in the baby, and it should start. It's a head-to-toe examination. It's a thorough head-to-toe examination. Okay, all right. So I think that's it. We will discuss in more detail bila kita buat by bedside. Is it okay? Is it alright? So I'm not going to open to question because I have meeting in a short while. But anyway, we'll discuss when we have sessions. So the group with me at 2 to 3 and then 3 to 4 in NICU. Okay? Alright, I've told to Dr. Nun. And tomorrow as well, the same time lah, 2 to 3 and then 3 to 4. Okay, all right. Okay, let's end our session with tasbih kafarah sotas. Okay, Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam. Thank you, Doctor.
Thank you.
Thank you, Doctor.
Thank you, Doctor.